Hello friends, I am Dr. Pavan Gulhane and this is the case as mentioned is a case of Asherman syndrome. She has undergone 3 previous abortions and you can notice this is the area of adhesions at the level of cervix and in the body of the uterus. This patient has undergone 3 abortions and 3 times DNC was done, and after that she was having decreased in the menstrual flow, that is hypomenorrhea, and after that she has undergone ultrasound and HSG which showed there are few areas of endometrium that is there in the cervix, mid body and fundus of the uterus, and after that we posted her for hysteroscopy and removal of the adhesions or excision of the adhesions of Asherman syndrome. This is the simple vaginoscopic approach that we use for all the patients of hysteroscopy. This is a cervix that can be visualized. Vagina appears absolutely fine, but if you notice the cervical opening, that is a external os is stenosed, and that was negotiated with the help of visual dilatation. Once we went inside the cervix, we realized the cervical canal was normal, but the internal os appears to be stenosed. We tried to push the scope through the internal os, but you can notice there is an adhesion right in front of us, and that is there in the that is starting from the internal os. We did the probe test for this patient, and this is the ideal thing to do, because if you don't do the probe test, that is pushing the instrument that you can notice right now, pushing the instrument in the uterine cavity and identifying the opening of the uterine cavity, and once you identify, you can cut these adhesions keeping that point of probe as a reference point, and then you can advance. Here also we cannot see anything, but you can see the gray dot, and we have pushed the Caesar through it, and this is a probe test. If you go in the wrong direction, there is a possibility you might enter into the subendometrial space and you will completely lose the uterine cavity forever. So once you identify the uterine cavity with the probe test, you try and cut the adhesions. Those are these white color fibers standing right in front of us in the layer wise fashion. You don't cut it directly in front, the fibers those are in front of us. You go sidewise towards the uterine cavity, come back, and then do the adhesiolysis of the remaining portion of the scar. You can notice here we have gone inside, cut, and then came back and again started adhesiolysis right from the cervix towards the uterine cavity. This way you'll try and avoid injuring more and more amount of endometrium, and if you can preserve maximum amount of endometrium, patient can have high chances of fertility. Now you can notice, as we have mentioned, in the mid cavity we had some portions of the endometrium islands, and you can see the ostium of the left fallopian tube. From here again, what you do, you go exactly in the center of the adhesions and try to cut it very by bit, and try and reach towards the fundus. And here also you can see the islands of endometrium is there in the fundus. This is the last portion of the adhesion that is going to be there, which will be taken care with the help of Caesar. The only problem when you do adhesiolysis with the help of Caesar, and as you notice we give a lot of pressure in the uterine cavity, the scar that is there that is causing the adhesion, that is going to be there even though you have incised it. So what I follow is to go and excise the scar that I'm going to show you later on. These are the adhesions, those are there on the left right lateral wall of the uterus. Here again we are doing probe test. We are pushing the Caesar inside and then going exactly in between the adhesion. Between, you can notice we are exactly in equidistant from both the anterior and posterior wall of the uterus. And once you do that, you avoid going inside the muscles of the uterus. And if you cut through the scar, there is a high possibility after excision of the scar, the endometrium is going to proliferate over it, and you will have good healing, and you can minimize the recurrence of intrauterine adhesions. This is the ostium of the right fallopian tube. Here also you can see the good amount of endometrium, and here you can notice there is anterior and posterior wall is having this scar. This white colored tissue that you see is a scar tissue, and we have to excise that to prevent the further recurrence of intrauterine adhesions. And for this precise reason, we use a bipolar resectoscope in this patient. If you notice there is some flimsy adhesions over the both ostial region, and it is very important to dissect these adhesions and free the ostium so that the passage of the sperm and transfer of the embryo becomes easy when the process of fertilization occurs intrauterine. Now we have gone inside with the help of bipolar resectoscope. One thing you have to be very careful to excise only the scar tissue and not to go beyond, so as to avoid excess injury that you might cause because of the resectoscope. So you have to be very superficial and try and excise only the scar tissue. This is a 18.5 French bipolar resectoscope we are using to excise the scar. It is advisable to use a bipolar resectoscope over the monopolar resectoscopes. But if somebody is using monopolar resectoscope, that is also fine. You can notice this white color scar tissue on the wall of the uterus, and you can notice right next to it we have normal endometrium on the right side. This is the posterior wall of the uterus where we had cut the scar, and I'm excising even that. You can notice how thin films I'm taking off the scar so that I don't injure the underlying muscles. There was a scar that was also present at the level of the internal os. You can notice this white fibers, and I'm going to excise even that. I don't want any scar inside, so that I can maximize the fertility preserving procedure that I am doing, and I can maximize the result for this particular patient. So that's it. We have excised the scar also and incised the Asherman's syndrome. You have to be very careful and quick to prevent the complications in this particular syndromic disease in the uterus. So that's it. We have achieved good amount of endometrium and the endometrial cavity. You can notice the endometrium that is present inside the uterus is more than 60%. So we definitely hope this patient to become pregnant in coming days. Thank you so much, and stay tuned for such kind of interesting videos with us.